Yes, you're good.
All right. So we're going to talk about patient safety. This is a large topic. It's kind of like being told you're going to give a talk on medicine, an overview of medicine. So I did kind of have to pick and choose the particular topics within it. We're going to see, how do I advance my slides here? Yeah. I have no declarations of interest. And so in general, what I hope to accomplish here today is I'm going to give a little bit of history and try to describe how did we get here. Then a little bit on how do we do it? How do we implement? What's the implementation arms of patient safety? And then what I want to do is to leave you with just a little bit of what I do. If I have time at the end, I'm going to introduce you to one safety tool that you can use today. So a lot of safety talks appropriately begin with a safety story. So I'm going to tell you a safety story over just a few minutes. So baby M was an infant born at 29 weeks due to premature delivery secondary to maternal chorioamnionitis. The delivery was otherwise uncomplicated. The patient did have respiratory distress in the delivery room, was intubated, and brought to the neonatal intensive care unit. This is a level 3 neonatal ICU. There were residents present there. The attendings were in their office immediately adjacent to the intensive care unit. The patient required vascular access, and so umbilical artery catheters and umbilical venous catheters were gathered, the flush solutions, etc. And the residents proceeded to place an umbilical artery catheter and a UVC. Shortly thereafter, the patient developed a wide complex tachycardia. The catheters were withdrawn, thinking that perhaps the catheter had been placed within the heart. The attending was called to the bedside, resuscitation was begun, electrolytes were drawn, blood cultures, antibiotics were administered. But unfortunately, the baby went on to lose a pulse and CPR was begun. Approximately 15 minutes into the resuscitation, the original electrolytes returned and showed a potassium of 8.3. Of course, repeat electrolytes were sent. We scurried around, scurrying about to try to find, was there any calcium at the bedside? There was none found. Syringes and fluids were all removed from the bedside. Calcium, bicarbonate, glucose, and insulin were all administered. CPR continued. The repeat electrolytes then returned with a potassium of 13.2. Patient, of course, subsequently succumbed. A search was taking place through all the bins, and as you might imagine, ultimately a vial of concentrated potassium was found in the discard bins. Now, at that time, nurses mixed up the medications and the fluids at the bedside. Potassium was not allowed in the room, but it was present in the unit. Notably, it was in a vial that looked very much like the saline vials, except it had a red dot on the top. It was otherwise essentially indistinguishable. The nurse who was present was not familiar with that intensive care unit. She was a well-experienced neonatal ICU nurse, but she worked predominantly at another unit. And so she had a limited understanding of where things were. And it's potentially she picked up this vial of potassium while looking for a vial of sodium chloride. At that time too, the syringes for the central line weren't prepackaged in the kit, and so they had to be drawn up at the bedside. I might note that the resident involved had been up and working for approximately 30 hours at the time. It was actually at the end of June. And this resident was cross covering for his colleagues so that they could go on a social event with the incoming interns. So this is a rather tragic story, but in many ways it's very typical of other patient safety stories. And notably, If any one of those holes in the Swiss cheese might have been closed, then potentially this is yet another patient that might have survived and instead succumbed secondary to medical error. So I want to start out with a little bit of history with regard to patient safety. And I know it's been debated as to whether Hippocrates actually said, first do no harm. For our purposes, we're going to say that he did, because then we can claim that patient safety has been a topic since 300 or 400 BC. So patient safety history goes back at least that far. I think this is a good, more recent quote. Medicine used to be simple, ineffective, and relatively safe. It is now complex, effective, and potentially dangerous. And I think that is the world that we all know that we live in. So you might be familiar with the concept of the keystone. The keystone is the stone without which all the rest of the wall falls. And so safety might be considered the keystone. If you think about it, without safety, patient satisfaction suffers, costs go up, physician satisfaction and staff satisfaction fails, we spend more time and we have less quality. Alternatively, however, if you focus on safety and promote safety, and safety improves, patient satisfaction increases, costs go down, physician satisfaction improves, quality goes up, and nurses and other staff are happier as well. So safety is the fundamental piece of performance excellence. It also, I might add, is the very basic, the fundamental part of what patients expect from us. Don't harm me, heal me, be nice to me, and in that order. So following through with a little bit of history, I want you to notice here, especially this study from New York. So this was published in 1991, and it was one of the first attempts to look at what is the prevalence or incidence of medical errors within US hospitals. And you can see in the state of New York, they found that there are about 3.7% of all admissions experienced adverse events. About 14% of those resulted in death. And if you extrapolated those numbers to hospitals all across the country, one came up with a figure that approximated about 98,000 deaths in US hospital due to medical error. So I want you to remember this figure of 98,000 because it figures prominently in the actions that took place after that. The next thing I'll point out, and people have often referred to this, you've probably heard of these books, this especially To Err is Human, published by the Institute of Medicine in 2000, and to a large degree it was prompted by the study we just talked about. And specifically, they acknowledged that 100,000 patients in the United States died every year secondary to medical error. It was a charge for the healthcare system and a charge for the United States to bring those medical errors out of the shadows, out of the darkness, and bring them into the light. It acknowledged that this was not a result or a product of bad people, but instead it was good people working in a bad system. It also noted that this obscuring and hiding of mistakes was in some ways understandable, particularly because of litigious concerns and liability. And it also presented recommendations for restructuring, reconfiguring, or recreating the healthcare system. The book that followed To Err is Human, Crossing the Quality Chasm, I put that on there because it makes the point that the difference between where we were and where we needed to be wasn't a gap at all, but it was described as a gaping chasm. So there was a gaping chasm between where we needed to be and where we should be and where we were at the time. So that's now brings us up to about 2000, year 2000. The next thing I want to tell you about and remind you of, some of you may be familiar with the 100,000 Lives campaign. This is a campaign of the Institute for Healthcare Improvement. And again, I want you to notice the figure of 100,000 lives. So based on that article, their campaign goal was to save 100,000 lives across the country in 18 months, acknowledging that approximately 100,000 people in the United States lost their lives every year due to medical error. So this was their 6 interventions. This is how they intended to accomplish saving 100,000 lives. And one of the things I want you to notice here is that this is very much the same list that we look at today with regard to patient safety. So the components were deploy rapid response teams, which is a relatively new innovation at that time. Deliver evidence-based care for acute myocardial infarction. Prevent adverse drug events by medication reconciliation. Prevent central line infections. And so this is when people began to talk about bundles. Bundles of interventions, process interventions that were designed, when applied uniformly, was designed to decrease the risk of central line infections. Prevent surgical site infections and prevent ventilator-associated pneumonias, again, by implementation of prevention bundles. So that was all back in 2006 and so what has happened since then? Well, this was from 2016, and it reinforces the fact that medical errors are considered the 3rd leading cause of death in the United States, second only to heart disease and cancer. This one study placed the number at about 250,000 deaths per year. Many have argued that that's too low a number, that the number is probably something more closely approximating 400,000 deaths per year, because they really only considered errors of commission and really didn't consider errors of omission. Also, about 12,000 unnecessary surgeries occur in the United States every year, 7,000 medication errors in hospitals. So sometimes we kind of lose sight when we look at those very large numbers, but just try to kind of bring it into something that we experience on a daily basis. That would be the same as if 7 airliners crashed every day. That's about 50 deaths per hour due to medical errors in the United States. I looked for data, and it's kind of hard for me to find data about how children are affected since I'm a pediatrician. I did find one reference that estimated that in the United Kingdom, 5 children die every day due to medical errors. So hopefully I've made the case that medical errors figure prominently in our healthcare and are a tragedy, and a call for action for all of us involved in medicine to try to make medicine safe. So why are there so many errors in medicine? We're a group of highly trained, highly motivated, heavily committed professionals. We're emotionally devastated when something happens to one of our patients, when we experience those medical errors. So why is it that errors seem so prominent and are so prevalent in medicine? Well, one simple answer to that question is that humans are reliably fallible. We tend to think on 3 levels: automatic, rule-based, and knowledge-based. Automatic or skill-based performance leads to errors of slips and lapses. So slips are, for example, when the nurse goes in and instead of turning on the antibiotics, they turn on the insulin infusion. I experience slips when I come down to the foot of the W road, and I usually turn right to go to the hospital. And instead that day I need to go to the mall, and I go ahead and turn right instead of turning left to go to the mall. That's a slip. Lapses are errors of omission. So that's when the nurse basically doesn't remember to go in the room and turn on the infusion or turn off the pump, etc. Those are lapses, errors of omission. We also operate on rule-based. So these are rules. So for example, a rule might be that when the presence of fever with an elevated procalcitonin, we administer antibiotics. So if X, then Y. So those are rule-based errors. And those are prone, those the rule-based thinking, and those are prone to errors of either applying the wrong rule or applying a good rule in the wrong circumstances. And then we operate on knowledge base. Now this is cognitively intense work. We have to maintain our focus. This is applied whenever we're in unfamiliar territory, that in particularly hazardous or dangerous places, novel circumstances. We have to apply what we know, our experience, and apply it to novel new problems. Now, again, there's a terrific book that's called Thinking Fast and Slow that kind of elaborates on the point that we as humans are disincentivized to work on this knowledge-based level. It's difficult for us. And so we tend to revert back to rule-based or automatic performance. And therefore, we tend to kind of make the rules work or make them fit even when they don't really fit. So we're reliably fallible. We operate on 3 levels, and each one of those levels of thinking can lead to its own kind of errors. Also, we're very limited in our cognitive capacity. I see this on here. It says that we can maintain in our memory 5 to 7 pieces of information. I don't know about you, but I think I err toward about the 5 pieces now. I'm not sure I can maintain 7 individual pieces in my short-term memory. Also, we all recognize the effects of stress. It increases error rates. Under stress, we tend to develop tunnel vision. We see only what's in front of us. We lose our situational awareness. I know that sometime during the year, you'll have a talk about the negative influence of fatigue on performance. And you may be aware that it's been said that 24 hours of continuous sustained work leads to cognitive impairment equal to an alcohol level of about 0.1 or 100. And also we have a limited ability to multitask, i.e. cell phones and driving. So another answer to that question is because we work in a very complex system. So this is just a graph here. These are as mathematical calculations that show number of steps in a process versus the probability of a success for each step. So obviously, if you just have one step and 95% probability of that one step, then ultimately at the end of that process, there's a 95% probability that that process was done correctly. So I want you to notice I'm going to focus on this 40 row here because it's been shown and estimated that for a standard medication order in a hospital, there's about 40 steps involved, 40 independent steps, each with its own probability of success between the order being written and the medication being administered to the patient. And so you can see that if we're 95% with each one of those steps, that there's only a 12% probability that that medication gets administered correctly to that patient. And even if we're 99.99% successful with each of the individual steps, still 5 times out of 1,000, that medication will be administered inaccurately or inappropriately. So we work in complex systems with multiple steps involved. If each one of those steps, there's a probability of failure, and we combine those number of steps, it decreases the likelihood that the patient is going to receive that intervention without error. It's also been looked at in complex ICU settings where researchers have documented an average of approximately 178 independent activities per patient per day, each of those with an error rate of approximately 1%. So again, it seems inescapable that we have to deal with error in our business, in our medical systems. Salvindi looked at the rate of errors in hospitals and found that errors of omission, For example, like forgetting to turn on a pump occur at about a rate of 1 out of 100. Errors of commission, misreading a label, turning on the wrong pump, reversing the order of interventions occur at a rate of approximately 3 per 1,000. And that severe stress can increase the error rate to as much as 25% error rate. So errors can be small or large. So with that introduction to error, I'm going to move on to talk a little bit about how we do it. So this is the arm, this is the implementation arm that I think many of you may be familiar with, and that is patient safety is related to, excuse me, to trying to reduce the rate of the incidence of hospital-acquired conditions. Many of these you're probably familiar with. Most of us are familiar with CLABSIs, CAUTIs, falls, bundles applied around CLABSIs and CAUTIs to try to reduce the risk. And certainly we celebrate the many successes that have already occurred in those areas. Surgical site infections, ventilator-associated pneumonias, needle sticks, medication errors, and pressure ulcers or pressure injuries. So those are some of the hacks. Forgive me the acronyms, but sometimes it seems like I'm in the Army and patient safety because there are all these 3 and 4 letter acronyms. So these are hospital-acquired conditions, and again represent one of the implementation arms of patient safety. Now, there are other hacks that you might be less familiar with, and so others that I'd like for you to consider is the harm from peripheral intravenous infiltrates and extravasations. We think about central lines, but there can be substantial harm from just peripheral IVs when they become extravasated. What about nephrotoxic acute kidney injury? Recognizing that some of the medications, contrast agents, et cetera, have the potential to do harm to the kidney function. Unintentional extubations, pulling out or removing endotracheal tubes at inopportune times or not the right time can result in injury. Venous thromboembolism, maybe even employee injury might be considered a hospital-acquired condition. DART stands for days away, restricted, or transferred. So that's talking about employees who sustain injury while on the job. And even antimicrobial stewardship in an attempt to prevent or reduce the risk of C. difficile, antibiotic-associated complications like diarrhea and electrolyte disturbance, et cetera. Even that might be considered as a prevention arm to reduce hospital-acquired conditions. So we obviously can't deal with all of those, but I thought I might just spend 1 minute talking about one in particular that perhaps you might be less familiar with, and that's unintentional extubations. So I've done a little bit of work about unintentional extubations in pediatrics, but I'll have to admit that I had to learn a bit about it in the adult world. And not surprisingly, it's a big issue in adult medicine as well as in pediatrics. When patients are unintentionally extubated, especially with cuffed endotracheal tubes, the cuffs are often up, and so there's a substantial risk for vocal cord injury. Certainly there's a risk for hypoxemia or hypercapnia, aspiration, and even cardiac arrest. This is particularly an issue for neonatal ICUs for a number of reasons. The length of the trachea can be as short as approximately 1 or 2 centimeters, and so it's difficult to maintain the tube in exactly the right position. There are issues with attaching the endotracheal tube, securing the endotracheal tube to the cheeks or to the mouth or through the apparatus. Sedation can present particular challenges in neonatal ICU, so it's known to be a particularly high-risk population. In neonatal ICUs, according to one study, about 18% of patients who were intubated, orotracheally or nasotracheally intubated, about 18% of those at some time during their course sustained an unintentional extubation. So that's about 14,500 per year in neonatal ICUs. The risk in adult ICUs is obviously somewhat less, about 7% or so. But multiplying that by the much larger number of adults in intensive care units, that averages out to be about 120 adult unintentional extubations per year. The estimated additional cost due to longer ICU stay and treatment of complications related to that unintentional extubation is estimated to be about $40,000 per patient event. So you multiply that by the 121,000 unintentional extubations in a year, and that equals to approximately $5 billion cost to the United States healthcare system for unintentional extubations. So again, I just brought that one hack out just to sort of focus on one that you might be a little less familiar with, but one could certainly say the same about the other hospital-acquired conditions and their opportunity to reduce harm and also to reduce cost by focusing on, rigorously focusing on preventing those hospital-acquired conditions. Another arm of patient safety is event reporting and cause analysis. And again, I'm not going to dwell on this for too long. My understanding is that sometime later in the year, you might have more complete instruction. But most of you, if you're not familiar with eSafe yet, you will become familiar with eSafe. I would encourage you to utilize it. I know perhaps some others on the audience might comment, but I know that Clear Visit every year, one of the things that they're interested in is the number of residents and medical students who access the event reporting system. So I would encourage you to utilize that. It's obviously important to, if events occur and they're not reported, they oftentimes don't get to the appropriate individuals who can take action on behalf of those. The event reporting system provides a template for assessing, investigating, and also defining interventions or risk mitigation strategies for those events. It also allows us to trend the numbers of events, i.e. multiplying the frequency times the severity potentially, and then administering or bringing to bear appropriate resources depending upon the severity and the number. So, and also cause analysis. So root cause analysis or parent cause analysis is an important part of implementation of safety. The next thing I thought I would talk about for just a minute is basically, which is another arm of patient safety, is identifying patients that are particularly at risk and bringing resources to bear to those specific patients and potentially rescuing them if they begin to deteriorate. So the concept here is that when patients are admitted to the hospital, we have an expectation as to how that they should recover. They're post-operative, or they've had bronchiolitis or had a myocardial infarction, et cetera. And we have in our minds an understanding of how we would anticipate that their recovery should progress. Unfortunately, those blamed patients don't follow our plans all the time. And so at some point along the line, they may begin to fall short of the anticipated recovery pathway. If this is detected early in the process, potentially changing antibiotics, bringing some resources to bear, calling the intern to the bedside, all those things can be implemented to mitigate that fall, and then can be corrected and brought back up on the appropriate curve. Should that fail, however, then potentially early warning scores may come into play. So early warning scores just tend to try to predict or identify patients who are at risk. In the pediatric world, the most common that we talk about is the pediatric early warning score, which is just a score that's based off of routinely obtained vital signs in the hospital. You may have seen in EPIC, I've seen it begin to show up a deterioration index. So that's designed ultimately, I think, to be an early warning score. Early detection of sepsis, I've seen that's flag in EPIC recently. But all of these are ways to try to identify patients who might be at risk and bring appropriate resources to bear to enhance their recovery. Should that fail, however, and patient continues to deteriorate, then perhaps medical emergency teams or rapid response teams might be in order. And this is a particularly important arm of the patient safety apparatus in order to bring it to bear for patients who might be at risk before the onset of a cardiac arrest. So I'm going to just talk about that for just a bit more, because I think this is really important for you to know and for you to participate in. So the rationale is that both in adults and in children, this has been looked at. Oftentimes, there are long periods of instability that occur prior to a patient suffering cardiac arrest. In one study, at least 6.5 hours, patients had had unstable vital signs or hypoxemia prior to an arrest. In another study, 66% of patients showed abnormal vital signs within 6 hours of arrest, and appropriate staff were notified only approximately 25% of the time. There is a reluctance to call a code. There's stigma associated with that, whereas part of the rationale for the rapid response team is to try to break down those barriers, eliminate that stigma, make it accessible to families, patients, and all the healthcare workers, all the staff, to make it comfortable, make it acceptable to call a rapid response. And obviously the goal is to call prior to the adverse event so that codes outside of intensive care units should become rare events. No patient should be in trouble and not able to get help. Now, this may be a little bit on the side, but I wanted to just make sure that we talked about all of us supporting rapid response teams. So these are the critical team behaviors in order to have an effective rapid response system. 100% of the time, the team shows up with a smile on their face in 3 to 5 minutes and says, "How can I help you?" About 30 to 40% of the time, and this has been looked at again in adults and in children, it's going to be a teachable moment. Maybe patient really wasn't in trouble. Maybe they weren't really deviating. Maybe this wasn't exactly the expected or anticipated course for that patient. So it's just a teachable moment. Again, smile on your face. How can I help you? Why did you call me? This better be good. Here we go again. Those are the comments, the attitudes. That's the kiss of death for a rapid response team. So I'm overtly asking for your support with regard to rapid response efforts. I know, at least on the children's side, residents are involved currently in the rapid response system. So we've really talked about central line infection, codes, rapid response team, surgical site infections, hand hygiene. All of these might be considered the tactical components of patient safety. But we should consider the strategic components as well, and that is safety culture. It's important for these things to work together. One cannot optimally exist without the other, but these tactical efforts should be embedded within a culture of safety. So this has long been the focus of patient safety efforts, but increasingly the focus is and should be on developing a culture of safety within the institution, within which all of these other efforts can thrive. So a culture of safety is something that's talked about a lot. I think it's a little bit difficult to define. This is the IHI definition: an environment in which providers can discuss errors, near misses, and harm openly, knowing that they won't be unfairly punished, and have confidence that reporting safety events will lead to improvement. That's the definition of a culture of safety. Just a little further description. I kind of liked this. I came across this as I was preparing for this talk, and this is 4 necessary characteristics of an effective safety culture. First, everyone is empowered, not just empowered, but expected to stop and question. And this is true not just when things go wrong, but when things just don't seem right. So we accept a low threshold for stopping the operations and empowering caregivers, support people, even the folks at the lowest on the totem pole, giving them the obligation to stop whenever there's a question of patient safety. We provide positive recognition for questioning, and there's zero tolerance for intimidating behaviors. Everyone is constantly aware of inherent risks. So this reminds me of the high reliability principle of preoccupation with failure. Everyone is constantly aware of inherent risk. No matter how complex or hazardous an activity is, if we do it repetitively, human nature is to minimize the risk and to let down our guard. Most people, even when they're performing highly hazardous activities, have performed it successfully many, many times, and there develops overconfidence and complacency. Instead, in a strong safety culture, we're constantly asking the question, how might the next harm occur? How might my patient deteriorate today? What can I do to mitigate that risk? What happens if that occurs? What was my appropriate response? This is a preoccupation with failure, constantly aware of the inherent risks of the things that we do. Thirdly, learning and continuous improvement are truly valued and supported. When we experience human errors or adverse events occur, the normal response in many institutions is to not discuss it openly. And instead, in institutions with a firm safety culture, these are considered golden opportunities for learning. Near misses are very valuable and are taken advantage of. They're shared among units that implement the prevention measures that are determined from those events, are shared between units and incorporated in near real time in educational efforts and in personnel training. And fourthly, teamwork is a requirement. So at first, that may seem quite obvious, but teamwork is especially important in patient safety. So when problems occur, normally there's competitiveness and pride emerges among close-knit work groups. It's easy to become defensive and talk in terms of they versus we. Mature safety cultures, this isn't tolerated, and instead, I'm responsible for my behavior, and I'm also responsible for your behavior. So I thought that's a pretty good description of what it's like, what I say a mature safety culture is like. So we also talk in terms of a just culture. And so obviously we can't have a system where that people aren't responsible for their own behaviors. And so it really is true that in a just culture, we are in fact responsible for our own behaviors. So if you just look at this brief abbreviated algorithm, most people don't come into the hospital today to hurt people. Most people come into the hospital today or in their offices to help people. But those who are malicious, obviously that's a different area, and those should be punished, taken out of the system as appropriate. Substance use should be taken from the system, and at least initially until they're have an opportunity to recover, given the help that they need, and then potentially return to the system. Those who violate rules, however, if there are repeated violation or risky behaviors that have occurred over time, then maybe those people need remediation or coaching. However, if we just make an error, we're all prone to making errors. And one way to look at it is by applying the substitution test. In other words, another person under the same circumstances with the same degree of training, might they have made the same decision or taken the same action as the person in question did? And if the answer to that question is yes, then that represents a safe harbor. We look at systems approach, and we don't punish that person for creating errors. Another way to look at that is that those who participate in reckless behavior are disciplined or sanctioned. Those who participate in at-risk behavior are coached. And those that are victims of all of our human error, those people are consoled, supported, because they, in a sense, are victims as well, uh, and are often quite distraught, upset, sad, isolated, lonely as a result of the error that occurred and potentially the harm that occurred to patients as a result of that. So I want to spend just a minute talking about communication, since it's such an important part of patient safety. I thought this is a terrific quote. The single biggest problem in communication is the illusion that it has taken place. So if you accept that effective communication is necessary to deliver quality patient care, then you might not be surprised to find that when you look at medical errors, there's a high incidence of communication failure. So one study looked at errors that occurred within a hospital and found that 62% of those errors were precipitated by communication error. Oftentimes, the source of that communication error was when one team of providers handed over to another team of providers. And so this study has been figured prominently, for example, in the IPASS literature that encourages communication tools at the time of handover. Joint Commission data would indicate that that communication failure is oftentimes one of the root causes for sentinel events. This says from 2004 to 2006. I looked at some more recent data, and it figures it's usually in the top 3 of contributing factors for sentinel events. Another review found that that looked at closed case files with regard to medical litigation, and found that also communication problems contributed to approximately 35% of closed case malpractice claims. And importantly, a large proportion of those involve trainees, either poor communication among trainees or between trainees and their non-trainees or attending physicians. This just reflects what I just said, that this is Joint Commission sentinel events and contributing causes. And notably, communication failure was noted in approximately 2/3 of all cases of sentinel events that were reviewed. I thought this was a good exercise to just illustrate how communication can fail. So I'm going to read the same sentence with a different inflection a few times, and I want you to notice how the meaning changes depending upon the inflection. So first, I didn't say he needs antibiotics. The implication being that perhaps somebody else did, maybe somebody else did. I didn't say he needs antibiotics. 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 So you see, just with a little difference of inflection, the meaning of that sentence changes, I think, rather dramatically, just depending on where the focus is placed. So there are a number of tools. What can we do about communication failure? We certainly don't have time to talk about all the potential tools. One, IPASS, I think you probably will hear something about IPASS potentially through other presentations. Timeouts, huddles, debriefings. SBAR has been talked about a lot, but I think it's still a really important tool to use to report events. The nurses talk about a ticket to ride. That's communication to in-hospital transport personnel. Hourly rounding, teachbacks, in dealing with patients, crew resource management. IHI has prompted an Ask Me 3 for patients. What is my main problem? What do I need to do about it? And what happens if I don't? Ask Me 3. And then three-way communication. I say something, you return that communication back to me, and then I respond back that it's been correct. So three-way communication. But suffice it to say that there are a number of communications tools that can be employed to try to reduce the risk of communication failure. So lastly, I want to deal with what can I do? So first of all, I would just say you can engage. You can participate in and support safety endeavors. So all of you will experience or have the ability to participate, for example, in safety huddles, daily operational briefings, pre-procedure huddles, post-event reviews. Hopefully you'll have the opportunity to participate in apparent cause analysis or root cause analyses. And I would just encourage you to participate in those activities because it's a much more rich and informed process whenever residents are involved. Certainly, all of us acknowledge the key role that residents play in medical care, certainly within our institution. I would encourage you to identify and report safety events. We talked a little bit about eSafe and how to access it. Like I said, I'm thinking that you'll have yet another session that deals with eSafe more specifically. But you have a unique perspective on and window into safety events. And I would encourage you to utilize the eSafe system and report them. Next, I would encourage you to notice and reinforce safety behaviors in others. One of the principles of safety coaching that's been brought about by the Solutions for Patient Safety is the so-called 5-to-1 feedback. We want to acknowledge and reward and reinforce behaviors, good behaviors, 5 times more frequently than we issue critiques of behavior. So you want to notice particularly patients, people, other staff members and colleagues who are engaging in safety behaviors, recognize it and reward it. And lastly, I would just say, speak up. So oftentimes, as you know, when safety events occur, somebody in the room has an inkling that something is going wrong. Things are perhaps chaotic, or sometimes it's not even a realization, it's more of a feeling. Some people have called that the pinch. So you feel that pinch, something's not quite right, it's important to speak up. And in that regard, I want to leave you with one specific tool, and that's the STAR tool. So all of you can remember STAR. This STAR stands for Stop, Think, Act, Review. It's something that you can do without uttering a word. You can do it by yourself. You don't have to make any noise. It's just a mental time out. So how do you do a STAR? It only takes 2 seconds. Stop. And that's the most important piece. Stop. Do not proceed. Pause. Think. What am I about to do? What are the potential implications of what I'm about to do? Do I have what I need in order to perform this task? Do I need the help? Do I have the experience? Do I need to ask for help, etc.? Stop and think. Carry out that planned task and then review. Did you achieve the results that you expected? Are there complications or other events that you need to be aware of? You need to be thinking about. You need to and perhaps review it with colleagues at the bedside or nursing staff at the bedside. Stop. Most importantly, stop, pause, think, carry out the act, and then review what just happened. Stop, think, act, review. So always take a few seconds, especially when distracted, fatigued, multitasking, under time pressure, or before a safety critical action. Stop, think, act, review. So I've tried to, in only a few moments, review kind of how we got to considerations with regard to patient safety, how we got to be where we are, a little bit of the history of patient safety. We talked about a few of the implementation arms, if you will, of patient safety efforts. And then I've tried to leave you with a little bit of a charge to say, how can you help? How can you participate? And how can you keep our patients safer? That's all I have.
Thank you, Dr. Hall. That was a wonderfully organized talk that really hit on the high points. We have about 7 or 8 minutes. Do we have questions for Dr. Hall?
Don't see anything in the chat.
Marvin, this is Bruce Shack. Let me echo what Dr. Court said. That was a wonderful presentation, very cohesive and coherent, and I think it's carried a very strong message, and hopefully everybody will benefit from it. And I appreciate you putting all this together.
Thank you. Thanks for the comments.
A few other comments. Dr. Hall mentioned eSafe. It is simple and easy to report an event. And it is certainly there's a link to it in the intranet. Also to remind you that all eSafes that involve residents or that residents report go to your program director for them to review. We would also encourage all of the residents to sign into the IHI Open School and do the patient safety courses that are there. There are at least 5 courses on patient safety. There are actually more, but it's PS 101 through 105. And we encourage you to complete those modules. Some of the departments require that, others do not, but it's a very good reminder to follow up on what Dr. Hall stated. Any other questions, comments?
This is Jeff Bennett. I just wanted to also thank Dr. Hall for this wonderful presentation and highlighting the additional value of reporting safety events. One of the things that's been determined to give physicians a greater sense of engagement and personal gratification actually is supplying information around events, participating in these event reviews. So I think it's really something that is empowering and something that is very gratifying when we participate in that. Just to give a statistic, only about 60 of the eSafes that had been reported in the entire year in the 2018 timeframe, and there were thousands, only about 60 were from residents. So we have a big opportunity to participate more actively and benefit from that participation, both as providers, as teammates, and really just as people.
I would just reiterate that residents oftentimes have a unique window into those events. And so without their input, I think we miss a lot. So I would encourage you to participate in the eSafe process.
A couple other things, just to remind everybody, if you want CME credit, if you're faculty attending and you want CME credit, the link to that CME credit is in the chat box, so you can get that. And also, if you have any questions about either registering for IHI or how to use eSafe, you can contact Kim Judd or Pam Scott, and they can help you with that. One other quick point is Dr. Hall talked about consoling as being one of the things that we need to be able to do as physicians for other physicians, but also for nurses, pharmacists, other staff. And consoling people is critically important. One of the areas that we often miss, though, is that as physicians, we need to be able to be consoled also and be able to talk about this. And for residents, we actually have a system that you can enroll in. If you've had a critical incident where harm was caused to a patient and you are what we call the second victim, feel free to, again, contact Pam Scott or Kim Judd about how to sign up for our second victim program that can provide counseling for you after that event. In my past, certainly there were a number of residents who felt, well, gee, I really don't want to do that. But I think when they were able to get some counseling around the event, it was very, very helpful. So don't hesitate to do that and sign up as that second victim program to receive some counseling. And again, that's through UT College of Medicine. Well, Dr. Hall, this was absolutely wonderful. It certainly covered all of the areas that we feel are the basics. Again, to remind people that you can go into the IHI Open School and take the modules that are on patient safety, and they will review what Dr. Hall has already covered. If there are no other comments or questions at this point, I want to thank Dr. Hall again and everybody else for attending. Have a great day. Be safe yourself. Help keep the other employees safe, and especially help keep the patients safe. Have a great day. Thanks very much.
Thank you.